The limitations of tube guides are known by anyone who has used them. As I said before, I'm an advocate of tube guides. They work great. It's just that they don't work great in all the situations we need them to work in. In our survey of actually 12,000 doctors, we had 875 respondents. They described the limitations of tube guides. And basically, its limitation is you don't have visual and physical access to the surgical site. Oftentimes, many tube guides have a large flange. And the doctors, pretty much all of the doctors, acknowledged they wanted physical and visual access to the surgical site. Another major issue is the need for increased vertical space. 77% were frustrated by the need for clearance. And more interestingly, they noted that in 30% of their cases, they didn't order a guide because of their concerns about vertical clearance. And finally, the cost of the guide and a surgical kit are quite high, and our respondents indicated that these costs were too high to use in 1 to 2 implant cases. And perhaps the most intriguing number was that they indicated 18% of the guides that they have received are discarded at surgery. So first we went after that. We said, why are 18% of guides discarded? And based on the experience that I've had and in speaking to other surgeons, it comes down to, I think, 4 items. One is planning error. Oftentimes, you plan the case virtually, everything looks perfect, and then you come to the mouth, and clinically it just doesn't look right. So sometimes there's a discordance between your virtual plan and actually what you see when you look live in the patient's mouth. Secondly, inadequate vertical space. Sometimes the guides don't fit, poor fit, they rock. And the fact that you can't modify this guide once you have it. If you get to surgery and say, well, I think I'd like the osteotomy a half a millimeter this way or that way, or a millimeter this way or that way, with a tube guide, you cannot change it. Either you go with the trajectory the tube guide gives you, or you can't use the guide. So if we just go look at planning error, what are the issues associated with planning error? Because these guides are based on the plan. It's like a computer. What you put in is what you get out. And in this situation, if the plan is not precise, if it's not accurate relative to the actual patient anatomy, then the drill guide will not be usable. Well, I think one of the issues could be is many plans are based solely on osseous anatomy, where while you're planning the case, you can't see the outline of the gingiva, you can't see the opposing tooth, you can't see adjacent teeth. Secondly, there seems to be a perceptual difficulty looking at 3D images in 2 dimensions. This issue was described to me by the owner of a large digital dental lab who indicated that they faced this problem when designing crowds virtually. And there's a learning curve here in which to overcome this issue, but to be aware of it is very important. And finally, plans based on 3D image with scatter can be a problem. Sometimes critical anatomy is obliterated, or the data merge may not be accurate. So if you have a scan and there's enormous amounts of scatter and you have anatomy that's obliterated, perhaps that's not a case in which to do guided surgery. With BlueSky Plan and Guided Surgery Solutions enhanced tools, I think that we are able to reduce the planning error. And these are the tools that would be available in order to do that. The plan is based on merged data, showing the osseous anatomy, gingiva, and teeth. Plans can be based on anatomy of the opposing dentition, anatomy of a temporary or permanent prosthesis, a full denture, or an edentulous ridge. We've also introduced the ability to plan on the basis of reference marks, showing pilot hole entry points that are in ideal anatomical positions. Radiographic stents are usually not needed, and we have a scanning protocol for cases with scatter where we still can obtain accurate merges. This slide illustrates some of the enhanced tools that we have available using BlueSky Plan. It's an extremely powerful software package, and and it enables us to do what we're showing you. In the top left panel, we can see a cross-section of a mandible with an implant in place. But we also can see the outline of the gingiva. We can see an outline of the opposing tooth. And in this case, you can see where we have the implant lined up, a mandibular molar implant lined up with the lingual cusp of an upper molar, is as it should be. In the center panel, there is an image, a 3D image of an articulated dentition. On the top right panel, we have an image of the edentulous area and the adjacent tooth, and you can see a reference mark. And that's a mark in that model which represents the ideal position for the placement of that implant. We also can use the abutments as virtual teeth. For molars, I usually set them at 10 millimeters. They can be whatever you wish them to be. It could be 9 for a smaller molar, 11 for a larger molar. And so you can look 3D on the actual model and see what the relationship would be between your future tooth and the adjacent teeth. And I think these enhanced tools will go a long way to minimizing planning error. The vertical space issue is one that everyone is familiar with. A tube guide requires you to stack the drill above the tube. The kicker is that we don't always measure the maximum interincisal opening of our patients as part of our pre-surgical plan. And so you have situations where the issue is not appreciated until the surgical appointment, at which point the guide is discarded. But the tube guides can easily add 6, 7, 8, 9 millimeters of vertical height requirement to a case. The ThinLayer guide addresses these issues by its design. First, we provide a snug-fitting disposable drill stop, and these are made custom for any drill system that might be used. So the first step would be to use an insert with an endo file or a sharp burr and create a bleeding point. And this replicates the ideal insertion point for the case. So you create a bleeding point. Then the drill, we use a Salvin spear drill, is inserted through the guide. The drill stop engages the guide hole, and you can now create a pilot hole. The tip of the drill goes into the bleeding point or the initial and creates a pilot hole. You then place your 2 millimeter pilot drill, and you insert the drill through the guide hole, but you can do it as an angle. So if you place it at an angle, you now require no more vertical clearance than you would freehand drilling. In other words, if the drill and the handpiece will fit in someone's mouth without a guide, it will fit in their mouth with a ThinLayer guide. So you drag the tip of the drill along the gingiva, insert it into the pilot hole, and drill to depth, as seen in the lower right panel. This procedure would then be repeated with drills of increasingly large diameters. We advocate that measurement of the patient's vertical opening should be part of the surgical plan, part of the pre-surgical workup, because this dictates whether surgery can be done or it can't be done, or if it can be done, this will dictate the length of your drill and the maximum length of the implant that you can use. And it varies for different drill systems, and it varies depending on the size of the head of your handpiece. So this is a chart which we have constructed, and it's just a small sample of our database, where we can tell you, if you tell us, in order to use our system, we need you to give us the specs on your handpiece. And we'll measure the handpiece, we'll measure the insertion of the drill into the handpiece, and know precisely the vertical space needed for a given handpiece and a given drill. And in that way, we can tell you that if you use a drill length, in this example, a BlueSky Bio short of 32.5 millimeters in a specific handpiece, we can say, well, under those circumstances, your maximum implant length is 10 millimeters, say. And so, again, this should be all part of pre-surgical planning. And in my experience, it has not been part of pre-surgical planning. And I think that's why in a number of these cases, the guides are discarded because of lack of vertical clearance, because this was not worked out ahead of time. Finally, I think we all would agree cost is a barrier to adoption. In our survey, a pretty obvious conclusion, but guided surgery would be used much more if it was less expensive. When you look at the cost breakdown of currently available systems, first you have the upfront investment in implant planning software. You have a software annual maintenance charge. You need a guided surgery kit, which is usually proprietary. And then the cost of the guides can range from $300 to $650 and up. Additionally, there are fees for a radiographic stent, oftentimes. If the file has to be merged or cleaned, another charge, and obviously a charge for treatment planning. With the ThinLayer system, it's based on BlueSky Plan software, which is powerful software, and that's free. There's no annual maintenance, and it works with almost all systems and most drills. You don't need special drills. And the single implant guides are $249, $50 for an additional site, and a charge for planning your case. I think at this point, Michael, if there are any questions, then I think if there are any questions at this point, it might be a good break to answer questions. If not, I'll continue on.
Well, if anybody has any questions, they can be entered into the chat box on the bottom right, and Dr. Haber could address them. Okay, I think we could continue onwards at this point.
Good. All right. So
I'll interrupt you if there are any questions.
Okay. At this point, I think I'll just review the characteristics of the ThinLayer guide system, that it's based on the enhanced BlueSky Plan planning tools. We need a model and a plan of the case. It's usable in molar sites and in patients with minimal opening. Requires the same vertical clearance as freehand drilling. You have physical and visual access to the surgical site. Works with most implant systems and drills. Custom disposable drill stops are provided, and radiographic stents are usually not needed.